Welcome to our presentation on multiple sclerosis, what it is, how it can be treated, and facts about massage, exercise, and its effects on MS sufferers. What is MS? What is happening in the body of someone who suffers from multiple sclerosis? In a healthy human body, nerve signals travel at lightning speed within the central nervous system. The way which these signals travel are along delicate nerve fibers, which happen to be surrounded and protected by a fatty silk coating called the myelin sheath. Traveling along the myelin sheath is communication between the brain, spinal cord, and our limbs. In people who suffer from multiple sclerosis, the myelin sheath is damaged in some way, possibly due to disease, injury, autoimmune disorders, or genetics. The body then attempts to fix the damaged myelin sheath and inevitably makes the problem worse. Multiple sclerosis gets its name from the body trying to fix the myelin sheath, causing scar tissue and hardened areas in multiple sites along the sheath, hence multiple sclerosis. The sclerosis of the myelin sheath creates stuttering communication signals from and to the brain, producing some of the symptoms of MS, such as decreased coordination, instability, and muscle spasming. As we can see in the diagram on this slide, the neuron on the right has damaged myelin sheath located at the Schwann region of the neuron. This is what causes the communication between the central nervous system, brain and spinal cord, to receive and send intermittent or sporadic information. The neuron on the left is smooth and healthy, and next we will look at the different forms of MS. MS is not an easy diagnosis as it can present as many other conditions, such as fibromyalgia, lupus, scleroderma, and even central nervous system tumors. Generally, there are 5 forms of MS that an individual can present with. They are benign MS, remitting or relapsing MS, primary progressive, secondary progressive, and malignant MS. Whenever a patient is diagnosed with a form of MS, they will usually remain in that same category for years or even decades before progressing to a more severe form. Unfortunately, it is rare that someone diagnosed with MS will have asymptomatic remission, meaning their symptoms diminish and don't return. However, MS is also rarely diagnosed as malignant, meaning their condition worsens rapidly and leads to an early death. How can massage help MS sufferers? Because of the complexity of this disease, most of our clientele will be on medication. There are many forms of medications available for MS, but most have an abundance of severe, long-term adverse side effects. Some of the more common drug categories used to treat MS symptoms are anti-neoplastics, which are used to quiet the immune system and are used to treat severe forms of MS. Antiviral and anti-proliferative immunomodulators, which help to quiet flares, limit the immune system's response to inflammation, and reduce the development of brain lesions. Our role as massage therapists when treating someone with MS is to help improve their quality of life. The many complications and symptoms caused by MS can be addressed with massage, such as decreasing pain, relieving muscle cramping and spasms, improving sleep, helping to maintain range of motion, and working with balance and coordination issues through therapeutic exercises. Depression is often accompanied with MS as well as self-image changes, considering people struggle with social situations given that their bodily movements may have become impaired due to the disease. As we know, depression and self-image or awareness can respond well to massage intervention. Although weekly treatments can be difficult for some to commit to, MS sufferers need to realize that infrequent treatments will not yield nearly as much benefit to their symptoms as will massage on a weekly basis. A good suggestion for someone can be 2 30-minute appointments rather than 1 hour-long appointment in a week's time. Here are two interesting MRIs of two clients battling with MS. Brain atrophy occurs with aging in the healthy. However, with brain atrophy in MS clients, it can occur up to 4 times faster. These MRIs show the amount of brain atrophy that can occur over just an 18-month period. The black spaces in the center of the brain, known as the ventricles, are enlarging rapidly. Also, the black spaces on the surface of the brain, known as the sulci, have dispersed just over 18 months. Brain atrophy is due to loss of axons and neurons, and meaning greater disability and decreased cognitive functioning for the client. As mentioned previously, this is why drugs are given to prevent brain lesions and slow brain atrophy. MS clients have a skewed reporting mechanism when sensing appropriate parameters for stretching techniques. Because of this, as massage therapists, we must ensure we do not stretch past the point of resistance with MS clients. This may cause a spasm to occur and increase sympathetic nervous system firing. MS clients usually react poorly to heat, and for this reason, increasing sympathetic nervous system firing is also cautioned, as this can raise core body temperature at deep, vigorous techniques, resulting in a flare-up. Red-hot, inflamed bony prominences are sometimes common because the client cannot feel the obvious signs and symptoms of skin infection, trauma, or impaired healing. MS is a complicated lifelong disease, and as massage therapists, we have the ability to decrease their pain, anxiety, and struggles and increase their quality of life. Next, we will look at a study performed that looked at the effects of massage therapy in combination with exercise therapy, compared with each therapy's results on their own. In the study we researched titled A Massage and Exercise Randomized Controlled Pilot Study on MS, there were 4 different groups that were analyzed. Group 1 was a massage group only, Group 2 was an exercise group only, Group 3 was a massage and exercise combined group, and Group 4 was the control group, which continued with their regular routine care for MS and was asked not to begin an exercise program. The main purpose of the study was to look at the effects of massage and exercise in MS clients with pain, fatigue, muscle spasms, balance issues, gait issues, and overall quality of life. In the study, most participants experienced their symptoms in their lower extremities, and for this reason the interventions were performed on lower limbs. In this flowchart, we can see the distribution of the participants involved in the study. Initially, 131 people were contacted to participate. To the left, we can see 11 were excluded because they did not fit the appropriate criteria, which we will look at later, and 72 refused to be involved because of their work schedules. This left 48 participants in total, which were divided up into the 4 categories for the study. 12 in the massage group, 12 in the exercise group, 12 in the massage and exercise combination group, and 12 in the control group. None were lost in the follow-ups, and therefore a total of 48 MS participants made up this study. Here we can see the demographics of the 48 participants in the study. Their age, height, weight, time since diagnosis, and their results after taking the Expanded Disability Status Scale. All participants were contacted by telephone and had to be part of the Multiple Sclerosis Society in their local community. To be considered, clients had to have clinically relapsing remitting MS or secondary progressive MS with their EDSS scores falling between 2 and 6. They also had to be able to stand unassisted for 60 seconds, using aids if needed, and had to be able to walk 10 meters safely with an assistive device if needed as well. Clients were excluded if they had had a severe relapse 1 month prior to the study start date, were already involved in an exercise physical therapy program, had unstable cardiovascular issues, diabetes, lower limb arthritis, or other neurological or musculoskeletal conditions other than multiple sclerosis. Now we will discuss the specifics of the treatments given to each group. The massage group received massage for 30 minutes, 3 times a week for 5 consecutive weeks. They were treated by a trained massage therapist, and the techniques used were Swedish massage as well as frictions. They were treated supine with approximately 7 minutes allocated to the quadricep muscles and 4 minutes to the peroneals for a total of 11 minutes unilaterally. In prone, they were treated approximately 4 minutes on the calf muscles, again unilaterally. Therefore, a total of approximately 30 minutes bilaterally was applied. The exercise group was given a combination of strength, stretch, and endurance training exercises. Again, the lower limbs were the main focus, and exercises such as straight leg raise, forward lunge, hip adductor, and calf muscle stretching were performed. Walking on a treadmill, cycling, and balance board training were also included. The massage and exercise group received approximately 15 minutes of active exercises listed above and approximately 15 minutes of Swedish massage intervention. The control group continued with their routine medical care and was asked not to start or take part in an exercise regime. Outcome measures measuring pain, fatigue, muscle spasms, balance, gait, and quality of life were evaluated in a random order before any treatments and immediately after treatment. The evaluator of the outcome measures was blinded to the study. Pain was assessed using visual analog scale, 0 meaning no pain and 10 meaning severe pain. Fatigue was measured using the fatigue severity scale, 1 indicating strong disagreement and 7 indicating strong agreement. Muscle spasms were evaluated at the ankle plantar flexors using the modified Ashworth scale. The modified Ashworth scale determines muscle tone on a scale from 0 to 4, 0 being no increase and 4 being rigid. Balance was assessed using the Berg Balance Scale and timed up and go test. Higher scores in the Berg Balance Scale indicates a higher level of functional balance. With the timed up and go test, patients were asked to stand up from a sitting position, walk 3 meters, turn back, and sit back down on the same chair. Gait was measured using walking speed 10-meter test and endurance 2-minute test. The client was asked to walk 10 meters as fast as possible, and the time was recorded in seconds. Then the client walks for 2 minutes, and the distance covered is measured in meters. The person responsible for taking the measurements walked behind the client to ensure safety. Walking aids were used if necessary. Quality of life was measured using a 54-question questionnaire by Multiple Sclerosis Quality of Life. Here is a table of the outcome measurements found for each group in the study, pre-intervention and post-intervention, and the difference between the two. On the next slide, we will look at this in a bit more detail. For your information, there were 10 females and 2 males in all experimental groups. The results of between-group differences in change scores shows that with the exception of the MS Quality of Life 54-question questionnaire, significant findings between all 4 study groups. Those in the massage group show significant larger change scores in all outcome measurements than the control group. The exercise group as well showed significant changes in outcome measurement scores except for the visual analog scale when compared with the control group. Those in the massage and exercise combined group showed significant larger scores in all outcome measures except for the modified Ashworth scale when compared with the control group. Those involved in the combined massage and exercise group showed better scores with the pain visual analog scale than those in the exercise group alone. No significant differences were seen between the massage group only and the massage and exercise combined group. Massage therapy resulted in larger improvements in pain reduction, dynamic balance, and walking speed than just exercise therapy alone. All in all, the results of the massage therapy group and the results of the massage therapy and exercise combined group are comparable. While this study sets a good baseline for the benefits of massage therapy and massage therapy in combination with exercise, of course we need to consider some limitations to the study. The sample size was quite small, only 48 participants. The pilot nature of the study is not always the best, but is better than nothing, and the lack of long-term follow-up needs to be considered. Here are the references for our presentation should you wish to look up more information. Thank you for listening, and I hope you've learned lots.